Welcome to the QSource ESRD Network's mini-lesson series for primary care physicians and hospitalists. Participants of Lesson 1 will learn the role of primary care physicians and hospitalists in chronic kidney disease, CKD, and end-stage renal disease, ESRD, care. When to refer to a nephrologist. When and how to refer for kidney transplant. The Advancing American Kidney Health Initiative, which was launched in July 2019, outlines specific action steps to transform kidney care by focusing on three goals: reducing the risk of kidney failure, improving access to and quality of person-centered treatment options, and increasing access to kidney transplants. The United States Renal Data System 2022 Annual Data Report contains data from medical claims through 2020 and for some ESRD-related metrics for the first half of 2021. Estimates of the prevalence of CKD vary considerably across sources of available data. Among Medicare Fee-for-Service, FFS, and Medicare Advantage, MA, beneficiaries aged over 66 years in 2020, 13.3% and 14.8% had diagnosed CKD, respectively. The prevalence of diagnosed CKD in Medicare FFS beneficiaries aged 66 years and older increased from 8.3% in 2010 to 13.9% in 2019 before decreasing, for the first time since 2010, to 13.3% in 2020. Nevertheless, the prevalence of diagnosed CKD remained much higher in 2020 than in 2010. Between 2000 and 2019, when the incident count reached a peak, the number of patients with newly registered ESRD increased from 94,466 to 134,862. This represents an increase of 42.8%. However, over this period, the adjusted incident rate fell by 7.6%. The total of 130,522 individuals with newly registered ESRD in 2020 represents a 3.2% decrease in the count relative to 2019. The AAKH initiative seeks to decrease kidney failure through better diagnosis, treatment, and preventative care. To achieve this goal, we need the collaborative efforts of primary care physicians and hospitalists who are part of the care spectrum for chronic kidney disease patients. Together, we can make a difference. Listen as Dr. Preethi Yerram shares guidelines for nephrology referral. Dr. Preethi Yerram is an associate professor of medicine in the Division of Nephrology at the University of Missouri, Columbia, and a staff nephrologist at the Harry S. Truman Veterans Administration Hospital, where she practices general and transplant nephrology. She also serves as the primary transplant physician for the University of Missouri Healthcare's Kidney Transplant Program. She serves as the medical director for home transitional care units, as well as acute dialysis units in Columbus, Missouri, and has been actively engaged in the ESRD network activities and advocacy. Dr. Yerram currently serves on the QSource Board of Directors and is a member of the National Forum of ESRD Network's Board of Directors and Medical Advisory Council. In her multiple roles, Dr. Yerram's focus is on providing education and improving the care of patients with kidney disease.
So firstly, I want to start about why should we refer patients to nephrology? I mean, like I said, primary care physicians are vital to screening and diagnosing CKD in our patients, but at a certain stage, the patients need to be referred for nephrology for some of the things that I'll be discussing now. So one of the first things is, if somebody has chronic kidney disease or somebody has, renal dysfunction, it's important to know if it is due to a reversible etiology. So it could be glomerulonephritis or something else that could potentially be treated. That can be identified and treated, so we could potentially reverse that patient from having a chronic issue. The other important goal is to slow CKD progression. So there are therapies available now, and a lot of those are available to our primary care physicians as well, like RAS inhibitors, now SGLT2 inhibitors. So those are the kind of things that we can use to slow CKD progression. But also, in addition, when things get more complicated, there are other comorbidities that develop in our CKD population. It is appropriate for those patients to be referred to a nephrologist for better coordination of care and maybe maximizing any type of supportive therapies that could potentially slow CKD progression. The next goal is to manage CKD related complications. So when we have a patient with chronic kidney disease, as the GFR goes down, they start developing other comorbidities like anemia, Bindal-Moon disease, some of which will require additional therapies. And in some health systems, they are even, those medications may be just allowed by the nephrologist to be used. It may need some extra expertise for to be prescribed to the patients. Again, going back to the Kidney Health Initiative, one of the goals is to increase the number of patients that receive transplants and go on home dialysis. For that to happen, we also have to start referring patients for dialysis modality education so patients can make a choice of what dialysis modality they want to be on. And that also ties into patients making decisions about going to home for dialysis, because studies have shown time and again that if patients are educated in a timely manner before they actually are urgently started on hemodialysis, because that's the path of least resistance, when patients are given the education and time to decide what kind of dialysis they want to do, most of the time they would pick to go on home dialysis. So if we are to get to our goals of increasing our home dialysis numbers, it's very, very important to refer these patients early on so they can learn about their disease and also modality choices, because it is a lot to take in and can be overwhelming. So you have to do it over a period of time, sometimes repeating some of the things because it's a lot of information to take in. And again, that ties into the same principle, the timely referral for kidney transplant. So, and this is something that I'll be discussing a little bit in my next few slides, but again, increasing kidney transplant numbers, that will only happen if we refer the patients early on, because it's not something that is a quick process. Patients have to go through a very extensive evaluation to be evaluated for a kidney transplant. And then, if they are found eligible, they go on the list, and then there is a long wait. So the sooner the patients are referred for transplant, the better their outcome. So it is, again, it all ties into referring the patient to a nephrologist, and then from there on, the patient will be referred for a kidney transplant. So for all of these reasons, nephrology referral would be important. And in the next slide, we'll talk about what are the indications in terms of clinical indications for nephrology referral. Some of the things that we need to look at in terms of why a patient would need to be referred to a nephrologist from a PCP or primary care setting is when the glomerular filtration rate drops below 30 ml per minute. So this is like your stage 4s and advanced CKD. So this is the point at which we need to start talking about dialysis modality education. This is when we start seeing some complications of chronic kidney disease, as I mentioned previously, anemia, bone disease, and other things. So if there is rapid decline in GFR, one of the reasons we sometimes get patients referred from a primary care setting is the patient has been following the primary care physician or provider for several years. Their GFR is very stable. We know that they had diabetes and hypertension, so there are reasons for them to have CKD. But maybe at a certain point you saw that the GFR is starting to drop very quickly, maybe 10% or 20%, within a few weeks or months, and it has continued to drop. So that would be an indication to refer the patient to the nephrologist, because there may be either just a progression of kidney disease versus, there may be a superimposed etiology that could potentially be treated. So that would be a good reason for nephrology referral. Proteinuria, again, if you see patients with diabetes, long-term diabetes, you may see that they are having, lower degrees of proteinuria for a while, and then after a while, they started developing increasing amounts of proteinuria, sometimes in the nephrotic range, so anything over 3 grams. So the more proteinuria they have, the worse the renal prognosis is going to be, the sooner they're going to end up on dialysis. This is especially true in diabetic patients. But if you were following somebody, again, as I previously alluded to, things have been stable, creatinine has been stable, proteinuria has been overall stable, you have them on RAS inhibition and maximize therapy at that, and suddenly you start seeing new onset proteinuria without a good reason, that would be an indication, because again, it could be a complication of diabetic nephropathy if the patient has a well-established case of diabetes with complications, versus it could be a glomerulonephritis, something like minimal change disease or membranous, or it could be something that could potentially be treatable. Resistant hypertension, again, as the GFR declines, we also see need for escalation of antihypertensives, but also there are patients that would have something like renal artery stenosis. So if a patient is having really difficult to control blood pressure in the setting of CKD, that would be an indication. So when you see patients with increasing creatinine trends or protein, as I previously alluded to, and you're doing your preliminary workup and urine analysis shows RBC CAS or a lot of RBCs in the urine that is not otherwise explained, like no UTI, no kidney stones, and you're seeing this happen, that's again concerning for some sort of a glomerulonephritis. So that would be a reason to refer as well. Hereditary renal diseases, there are patients that have, like, let's say Alport's or polycystic kidney disease, juvenile nephronophthosis. There are things that run in the family and they're already aware of that. Early referral would be indicated in those patients because most likely these patients would develop end-stage renal disease, or potentially there are newer therapies that may be available for these patients. Again, recurrent or extensive nephrolithiasis. So if you have a patient with like one kidney stone here and there, that's fine. But if you know that these patients are like stone formers, have had multiple procedures or needing intervention repeatedly, that is, a risk factor for chronic kidney disease, because these patients do develop AKIs repeatedly and then, go on to develop CKD and possibly end-stage renal disease. So in these recurrent stone formers, there are interventions that can be taken to decrease the stone formation risk. So that's a good reason for referral as well. Electrolyte disorders, hypokalemia, hypomagnesemia, or hyperkalemia on the other end, where the patient is having decreasing GFR and you're having trouble maintaining the potassium. So there are several new medications that are available that could be used, but also in certain resistant cases, if the GFR is low enough and, we are not able to medically manage, sometimes we may have to do dialysis in these patients for various electrolyte disorders. Proteinuria and renal dysfunction in pregnancy, again, that's a very complicated situation, clinical situation. So definitely in anything related to pregnancy, if there is proteinuria and renal dysfunction, that would require a nephrology referral, because some of these patients may even require a biopsy based on the renal function at the time. And finally, if a patient has a history of kidney transplant, they are being treated with immunosuppressive medications and may have a transplant-related comorbidities. While the primary care physician or provider is going to play a very vital role in their regular care, they also should be seen by a transplant physician or a nephrologist, on an ongoing basis, at least at some interval. So with that background, I think, this is a great tool. This, I think, graphically represents, when somebody should be really referred for transplant for sure, but also how the risk varies depending upon where the GFR is. So obviously green is, great. Yellow and orange are, kind of poorer prognosis, and red, definitely the darker reds are poorer prognosis for renal decline. So when you see decrease in GFR in combination with increased amounts of proteinuria, so as you can see here, the G5s or even G3, G4 with A3, which is higher degrees of proteinuria. So they have categorized proteinuria in A1, A2, A3 with increasing amounts. And the GFR categories are like, the GFR is going to drop as you go down the numbers. So higher degrees of proteinuria with lower GFR obviously is higher risk for kidney failure. So those patients definitely need to be referred. And this gives you a good pictorial view of like the heat map of, when the patients really need to be referred and when they can be monitored in the primary care setting.
Thank you for joining this mini lesson from QSource ESRD Networks. Please visit us for mini lessons 2, 3, and 4. For questions, contact a member of our quality improvement team at the email address on the screen, or visit us on the web at esrd.qsource.org.